speaker for today is, he doesn't need an introduction. His name is Dr. Arif Tajjamul. He has done MBBS, MD, MSCOG, FSCOG, ex-principal of Islamabad, head of Gyne at Jinnah, and 26 years of experience in Obs and Gyne. The topic for today is fibroids and infertility.
And it's 36 years and not 26, so don't miss a decade. It's more of a lifetime than anything else. But I wish it was 26, then I'll be 10 years younger. But that's not happening, so might as well keep the record straight. Now, any medical student in 4th year, when they enter the gynecological floor, one of the first things that they come across are fibroids. They are as common as gynecology itself. And if you look at the overall picture, the number is 40 to 80%, which means up to 80% of women all across the world would get some sort of an encounter with fibroids. It doesn't mean that most of them will have problems because of fibroids, but they are very, very common. They are the benign neoplasms of the uterine muscle, and they come in all forms and shapes, and come with problems and without problems. But the commonest age group is between 30 and 50, and that is the age group that we mostly deal with in our infertile patients. Conventionally, we were taught as fibroids belonging to 3 categories: one the submucous, the second the intramural, and third the subserosal. These are further divided into a total of 8 categories, going from inside out. If the fibroid is totally into the uterine cavity, that is a submucosal fibroid and called as 0. If 50% or less is into the cavity, then and the rest is intramural, that's 1. More than 50% is in the muscle, it's 2. Similarly, a fibroid which is totally into the muscle, an intramural fibroid, is a 3 and 4. And then once it starts to go out of the uterine cavity, if it's less than 50% in the muscle, then that is a 5, and then a 6, and then a 7, which is a subserosal and pedunculated. And then the 8th one is a special category like parasitic fibroids or fibroids in the cervical region or into the broad ligament. So these are the various sites where you would encounter fibroids along with the common symptoms, and I'll come back to symptoms in a few minutes again. So the commonest presentation is asymptomatic. They are either an incidental pickup on ultrasound or on surgery, and most of them do not cause a woman any heartache throughout her life or her reproductive life. And if they are to cause problems and symptoms, it usually depends upon their number, their location, their size, whether they cause menstrual loss excessive in amount or not, if pain results from them, and then especially infertility, which is the crux of our topic today. And you know, we seem to have the technical issue again. ये वही याद हो रहा है कि जिस तरह शादी पे रात के 10 बजे बत्तियां बंद हो जाती, because then you're told कि आप घर जाओ. Infertility in fibroids, 5 to 10% of infertile patients have fibroids, and in 1 to 2.4% it is the sole cause of infertility. Now, it's not easy to prove that fibroids are causing the infertility, and sometimes we do get carried away with the fact that the patient is not getting pregnant. We see fibroids on a scan or otherwise, and in order to do something to benefit her, we start to deal with the fibroids. But then there is enough evidence now that unnecessarily addressing the fibroids can actually enhance the subfertility or complicate things. So one message which I definitely want you to take home is that every fibroid does not need treatment, and actual surgical management or medical management of fibroids can actually reduce fertility rather than enhance it. So you have to be very sure that this is a fibroid that you really do want to leave. So why do fibroids cause infertility? And there are multiple reasons. They can hinder into the gamete transportation. There might be problems with the sperms ascending into the uterine cavity. There can be obstruction of the tubal ostia. Sometimes you see fibroids sitting right at the entrance of tubes into the uterus, and they cause physical problems into entry of the gametes into the fallopian tubes. They can alter the uterine contractility and uterine function by local release of prostaglandins. If they are projecting into the cavity, they can actually work like an IUCD and impede any attachment of a new embryo there. And then they sometimes give rise to complications like irregular bleeding from the site of the fibroid in the uterine cavity, or can give rise to miscarriages as well. So, should we be offering surgical treatment to these patients? Well, definitely some, because there is evidence that in about half of the infertile women with fibroids, which we think are responsible for their infertility, they do get pregnant. And if we look at the patients entering the labor ward who had fibroids, they at least had 2 years of infertility preceding them, quite a few of them. So fibroids do cause infertility, and in a sizable number, the treatment of fibroids result into fertility. Recurrent miscarriages, we do need to look out for fibroids, and we do notice that surgical management of these fibroids reduces pregnancy losses, especially the first and even the second trimester losses. So, which fibroids affect fertility more? If the woman is older than 35 years, with fibroids which project towards the cavity, if the number of fibroids is more than 5, if the volume of fibroids is big, if the uterus is full of fibroids, and if the individual fibroids are large in size. And these are actually the factors which would help us in deciding which of our patients warrant surgery and which ones don't. If patients have recurrent pregnancy losses, then myomectomy usually is a good place to start. Now, I've had multiple patients who've gone through IVF cycles with fibroids, and I do not offer every patient myomectomy before opting for IVF. But then you have to pick and choose. I've recently had a patient, had an IVF cycle. Once we had the embryos frozen, I've now done a myomectomy because I did not want to open her belly up and compromise the ovarian reserve even more. So you have to actually pick and choose what would you want to do with your patients. Sometimes you would want to do the cycle first, freeze the embryos, then carry out the myomectomy, and then go for an embryo transfer in 3 to 4 months' time. That is what I now consider is probably a good idea rather than offering them myomectomy up front. Some mucosal fibroids have to be taken out if you're looking for fertility. You cannot leave them there and expect the woman to become pregnant, or if she becomes pregnant, to carry the pregnancy. They need to be managed. They can be managed in multiple ways. I'll get to that in a minute. But if you see a distortion of the cavity, that has to be addressed. So even intrauterine fibroids, which are partially projected into the uterine cavity, need to be addressed. But if the fibroid is well clear of the endometrial cavity, then you should really consider that if you can do away with the myomectomy, you should. जो मैंने पहले prognostic factors बताए हैं, अगर तो उनमें से कोई factor active है, तो then those are the patients where you would rather offer them myomectomy. Otherwise, if you see asymptomatic fibroids or fibroids with some menorrhagia, but no other reason to warrant surgery, then don't. Subserosal fibroids are no problem at all. They should just be left alone. They have no bearing upon fertility, and they usually do not cause any symptoms except when they increase massively in size, and you have to take them out for very different reasons and not fertility. So what are our treatment options? You can use GnRH analogs, or you can use selective estrogen receptor modulators. You can treat them radiologically with embolization. You can take them out either hysteroscopically or using a laparoscope, or carry out a conventional laparotomy, or you can use one of the newer modalities like high intensity focused ultrasound, which causes necrosis at the center of the fibroid, or a radiofrequency ablation, which is like a microwave. Now, I have never had good experience with GnRH analogs. The fibroids do reduce in size, but if you leave them alone, the size starts to come back. And many of my colleagues favor using GnRH analogs before surgery for fibroids. I actually find that it makes the surgery more difficult, because a softer fibroid with inability to define the capsule actually is much more difficult to retrieve from the uterus. So I do not use GnRH analogs no matter what the size of fibroids. I find it easier to deal with hard fibroids rather than necrotic soft masses. But if you really want to reduce the size, you can probably use a GnRH analog for 1 to 2 months before surgery, and that will certainly reduce the size and the blood supply to the fibroids, if that worries you. You can use the raloxifene, which is an estrogen receptor modulator, and this can be used with GnRH analogs or alone to reduce the fibroid size and vascularity. Uterine artery embolization, I think no month goes by without patients asking me that they do not want a myomectomy and they would rather have this. And I've heard the biggest source of medical information and literature for these patients is the Facebook. And some of my colleagues go out of their way to post things that they do these things, and they are very beneficial for every patient, even somebody who's contemplating fertility. Please read the line in bold words. It is not recommended for women who desire pregnancy. Why? Because we cannot predict the amount of ischemia the embolization will induce upon the uterus and how this uterus would react in another pregnancy. So if you really want to get rid of the fibroid, then get rid of the fibroid. Don't play games around the fibroid and then hope that it is not going to alter the uterine blood supply in a way that will affect a future pregnancy. There are no definites in this game. So do not offer treatments which we cannot predict the outcome. So, pound for pound, I think surgery is a much better option than medical management, because you're actually getting rid of the fibroid and restoring the anatomy, which I think is much more important than just shrinking the size of these fibroids. You can take them out hysteroscopically, and again, I see a lot of this going around. Patients, obviously for good reasons, do not want a laparotomy and want a simpler solution to that. But fibroids which are a little deeper into the myometrium, removing them through a hysteroscope can be dangerous. And second, I've seen multiple partial removals of fibroids hysteroscopically, with the fibroid going back again or fertility not being restored. So if you've got a pedunculated hanging fibroid in the uterine cavity, then that's probably the best solution, that they are removed hysteroscopically. But if you've got a fibroid which is 50% into the myometrium and 50% hanging into the cavity, then using a hysteroscope to remove it is probably not such a good idea. And theoretically, you can actually go through the wall of the uterus with a dissectoscope and cause damage to pelvic and abdominal organs. So I'm not a great fan of that. You really have to be sure that the fibroid is totally into the uterine cavity for you to take it out. And obviously, if you take it through the uterine cavity, there is some risk of adhesions as well. But mind you, every myomectomy has a risk of some damage to the endometrial cavity. And every myomectomy has a risk of actually causing intrauterine adhesions. So myomectomy should only be carried out by gynecologists who have experience in myomectomies. It's a much more sensitive operation than taking the uterus out. You have to be much more of a professional with good experience in order to offer myomectomy to patients. But if you're worried about it, you can actually insert an intrauterine contraceptive device into the uterus. I've never done it during the myomectomy, but that is one option which is available. You can probably do it later as well. That is of benefit or not, I do not know. You can use intrauterine balloons. You can use hyaluronic acid gel. You can put them on oral contraceptives or hormones to make sure that they have predictable good bleeds, and bleeds are anti-adhesions, because if the endometrium sheds, then chances of adhesions forming into the uterine cavity is a little less. So you need to pick and choose if any of these modalities are for you. Laparoscopic myomectomy, again, it's not the easiest of procedures to do, and should only be offered by gynecologists who actually know what they are doing. Because it's very easy to produce a hematoma from where you've taken the fibroid out and then suffer the consequences later. And then, if the walls are not restored properly, or if a bake area results in the uterus, there can be a risk of uterine rupture in a following pregnancy. So again, laparoscopic surgery for people who know what they're doing. This is what most of us do. This is what I do. First of all, be sure that the fibroids have to come out. Then try to use the minimal most number of adhesions of the incisions into the uterus. Try to make sure that you do not put any incisions on the posterior wall of the uterus. It is notorious in forming adhesions. And then it's probably a good idea to open up the cavity and look for some mucosal fibroids. I've seen some mucosal fibroids being missed because the gynecologist was afraid to open the endometrial cavity. In my very early years, I've done that too, and I've missed some mucosal fibroids. So it's always a good idea, or carry out hysteroscopy before doing the myomectomy. If you really don't want to open the endometrial cavity, do a hysteroscopy before offering the myomectomy, so that you exactly know what's inside the uterine cavity. But opening the endometrial cavity does not compromise it if you restore anatomy properly. So live birth rates are reasonably comparable if you look at different modalities. They're not that bad. And myomectomy, like any other surgical procedure, has its own risks. And it does weaken the uterus, and this is like a classical scar in the uterus. I do not offer my patients vaginal delivery after a myomectomy. So I consider all myomectomies to be classical scars because they're usually into the muscular area of the uterus. These techniques, they're there, but I think they are for women who have had their pregnancies and have had their fair share of fertility. And offering them to patients in their fertility age group is not such a good idea. But they are there, you can explore them, you can refer your patients for these things, providing you know that the patient belongs to that group where offering this treatment is worthwhile. Radiofrequency ablation, again, you need to be sure that the other organs and pelvic viscera are not affected by these things. So in conclusion, most patients have fibroids. All fibroids do not warrant treatment. If a patient warrants treatment for fertility, surgery is probably better than medical management. In offering surgical management, be sure of which technique and what myomectomy you need to carry out. After the myomectomy, make sure that you do not damage the genital tract in any way to compromise fertility further. Do a proper follow-up and allow for pregnancy when you think the uterus is healing well. During the pregnancy, please note that this is a weakened uterus and you have to keep an eye on things no matter how good the healing. And I myself will not offer vaginal treatments after myomectomies. And then again, these patients deserve all our care, like all other of our patients, and sometimes do need a good discussion before proceeding with any of the operating treatment. Thank you very much.
He is a consultant urologist and a male fertility specialist. He is a Dow Medical College, Karachi graduate and holds fellowship from Royal College of Surgeons, UK and European Board of Urology, technical advisor and lead surgeon for UNFPA. I would like to call upon stage to give this honor.